I'm Ahmed Najjar and will be presenting to you two small presentations as part of your uh, year two CRF course. And as you know, this course was given previously by Professor Nasif, who unfortunately uh, left us. So I will be replacing him for these two lectures. Just allow me to restart or find out the presentation. So, do you see the screen now? The presentation is obvious. It is
Yes,
displayed.
Celebrate.
Okay, Bismillah. So please stop me if you have any questions. It's gonna be quick ones. So first lecture is gonna be the topic is fluid management. So you are lucky to get exposed to this early. It's a high yield topic for every physician on your road to become, inshallah, consultants and experts in the field. Essential and important part of your daily life. When you face every patient, you need to think about fluid management and whether this patient needs fluid or not. Okay, so specifically for this course, you're going to need to know these learning objectives, basically to understand what is basic fluid and electrolyte balance physiology, know a little bit about how to monitor this physiology and what are the indices that this is working or not. And yeah, specifically, you really need to know about the shock and trauma and how they affect the fluid balance and eventually the cardiovascular system. You need to know the indications and the complications of each type of fluids, and you need to assess these requirements and to know different side effects of different types of fluids. Uh, so, uh, let's revise and review basic physiology. You know, each one of us is made of about 60 to 70% of water. For example, if you calculate roughly a male with 70 kilograms body weight, you will find 42 liters of water, and it's a little bit different between male and female, but it's a general estimate. So this water mostly found in the intracellular fluid. So inside the cells, there is most of the water. So we can say if you take a 70 kilogram male patient or male, that doesn't mean to be sick patient, you will find about 28 liters of his water found intracellular compartment, and the rest will be extracellular. And so you can roughly say that 40% of body weight is intracellular and the other is extracellular. So, for example, if we give you in the exam 42 liters, you will divide it between 28 liter inside the cells, 14 liters outside, and this 14 liters, you need to divide it between the intravascular and the interstitial fluids. So the intravascular is about 25%, which is going to be about 8.5, 3.5 liters, and the interstitial is a larger volume, is 10.5 liters. So if somebody's ask you what is the percentage of fluid which goes inside the blood vessels is actually the least, which is 25%. But honestly speaking, it might be the most dangerous type of fluid. So if you lose your blood quickly, then it might be very dangerous. Okay, so the fluid is in continuous movement. You different type of fluids. So you have the nutrients, you have the waste products, you have the substances. They move in and out of the cells with water. And this movement is very important because if you don't have this water movement, then you cannot move your nutrients and waste products. Uh, what mechanism regulates this? There are different mechanisms, but the most important are one, membrane permeability, two, colloid and osmotic pressure, three, hydrostatic pressure. Membrane permeability, this lipophilic, hydrophobic, hydrophilic qualities of the membrane, and you need to know a little bit about all of that. What is colloid and osmotic pressure? Colloid and osmotic pressure is a form of force that delivers fluid out and inside, or out and inside each compartment. And it means roughly the the pulling pressure of the materials. It is the opposite of the hydrostatic pressure that forces water out of the compartment. So, osmolality, it means how much concentrate, so it indicates the solute concentration in the body fluids. For example, sodium, potassium, calcium, chloride, etc. So the most important osmolarity you need to know is the plasma osmolarity. And the plasma osmolarity or osmolarity, you need to know about this. It is 275 to 295 milliosmol per kilogram. Okay? And I tell you, and I don't need to repeat, you need to know what are the things that make up for the plasma osmolarity. And here you have it. The plasma osmolarity, it's made of plasma proteins, salts, electrolytes, and the waste products, urea and food molecules. So most of the time, the plasma proteins, they are the main colloid osmotic pressure because they withdraw and keep water. That's why when you have low protein, you are at risk of developing dehydration because there are no proteins that can keep water inside the blood vessels. Okay, so let's talk about hemorrhagic shock. Hemorrhagic shock, basically you are losing your blood. And when you lose your blood, you are losing plasma, you are losing RBCs, you are losing white blood cells, you are losing that osmotic pressure. So you cannot keep water. So that's why it is classified under a type of hypovolemic shock. You are losing volume, and its severity depends on how fast you are losing the blood. That's why you should learn a lot about hemorrhagic shock and when and what is needed to be done for the patient. So you need to know this. Hemorrhagic shock is classified in severity into four classes. Class 1, volume loss less than or blood loss less than 15% of blood volume. Class 2, 15 and 30. Class 3, 30 to 40%. And class 4, more than 40%. and usually class 4 are really very morbid and deadly. So, in general, you can calculate the normal blood volume in a male or female by using these equations, and you need to know them. The male has roughly 66 ml of blood per kg, and female have about 60 ml per kg. So, if you're having a male of 60 or of 70 kilograms, then he roughly has about 4.5 liters, 4.6 liters. So if you are losing about 2 liters, so you divide it 2 ala 4.6, and it means it is very dangerous. Class 4, it's about more than 40% of the blood volume. And please be aware of the difference between adults and pediatrics. The younger you are and the very old you are is the more dangerous because you don't have that volume and you don't have that coping mechanism to counteract the loss. Okay, so let's give you an example. A car was found on a country lane with the front end embedded in a tree. And you arrive, you find Hassan, who is 18-year-old, unconscious, and his right leg was trapped beneath the engine. The so you have very serious emergency. The ambulance came, and the timing is very important. We don't know how much time the ambulance took to come, but let's be very realistic and optimistic and believe that the ambulance came very fast. So they found him pale, cold, and clammy. So he has all signs of shock. Uh, Although there was a little sign of external bleeding, so he did not lose his all blood yet. His pulse was very weak and rapid, so this is a secondary physiological phenomena, and he was breathing rapidly. No blood pressure reading could be obtained. So he is he is having pulse, so we don't need to do a CPR. And we will talk about this later. An airway, because the patient was unconscious, so we need to secure to do the ABC. And nowadays there is a little bit of change toward CAB. So you check the circulation first and the airway and in the breathing. But in general, you can take it ABC for now. So the airway was inserted and oxygen given by mask. Intravenous cannula was inserted rapidly. And in this situation, you need two large intravenous cannula. And there was rapid infusion of gelofusine, which is some intravascular expander fluid that you need to give fast to expand the volume to be able to give blood for each organ. So the fire brigade sent a vehicle with cutting equipment and he was freed from the car. Okay, so they cut the car in order to free the victim. It was obvious that his leg was broken, but no clear other injuries were apparent apart from bruising over the lower part of the sternum. So he might have a direct hit to the heart and the chest. Okay, so an initial assessment was carried out on arrival in the emergency department. Hassan's blood pressure was 90 over 60, which is the definition of shock. Heart rate was 140 per minute, which is tachycardia, and respiratory rate 39 per minute, which is tachypneic. His auxiliary temperature was 35. It's a little bit low, so he is going into all the sequelae of severe shock. Blood samples taken quickly, low oxygenation, and hemoglobin was low. There was both respiratory and metabolic acidosis and raised plasma lactate concentration, which is a hallmark of shock. Okay, so and then we know that this patient is having shock right now, and it's hemorrhagic because this is the source of the shock because he's using losing blood. Okay, so what to do now? We need to resuscitate the patient. We need to adjunctively and concomitantly monitor this patient. We need to analyze very fast these data in form of laboratory findings, invasive procedures, stuff like that. Okay, so clinical monitoring, we have it already. We have our heart rate, we have the blood pressure. We will need to check the mucous membranes, which are pale. We might have cyanosis as well. The sensory level, we have it. The patient is unconscious. Orthostatic hypotension, we cannot do it right now because we cannot make the patient straight up because he is already comatose and he is flat. Urine output, we need to assess it somehow by inserting a Foley's catheter if we can, or to check if he is producing or if he had lost some urine. Signs of external bleeding in this patient, we have his leg as a witness of this bleeding. Okay, so we see that this patient is in class 4 hemorrhagic shock because he's lost more than 35% or 40% of his blood. He is his respiratory rate is high, his heart rate is more than 140, and his blood pressure is very low, and the pulse pressure you can measure it, and the neuro he is unconscious, so he's already class 4 urine output. We need to to see if the patient is having urine or not to decide. So this table is very important. You need to know the difference between all classes, and you need to know when to really the intervention is needs to be very fast or not. It needs to be like on the moment, on the point, or on the moment or not. Okay, now so clinically, we know clinically how severe the shock is. Now we need to do the lab investigation to confirm. So we measure hematocrit, we do ABG to measure the pH, and especially in acidosis, urine specific gravity, sodium level, chloride level, blood urea nitrogen, and creatinine and serum lactate level. And believe me, the most important is the hemoglobin, the lactate, and the hematocrit, and the others are important but not as important. So do not wait for the drop of the blood pressure. In the absence of hypotension, if you are suggesting a shock, please act fast. So we only need the history that we have and the physical examination. We have a patient who is unconscious, severe car accident. There are signs of external bleeding. There are signs that the patient is losing volume. So please right away move to management and monitoring. So systemic vascular SVO2, so the saturation is low, the blood lactate is high, the perfusion related acidosis, we have it, and there is increased base deficit. So we have all the data that tell us that the patient is in shock. Okay, so we have also, so we started the treatment. We need to monitor. we have our invasive procedure. The most important is the oxygenation. We can do ABG, arterial blood gas is the standard. If you don't have it, venous is okay. Next, central venous line, CVP, central venous pressure is important. Direct arterial blood pressure, if you have an arterial line, is very good. And Swan-Ganz catheter, which generally indicates a central perfusion. I mean, this catheter goes right away into the lung and it indicates how severe is the shock. The arteries, the central arteries, which is the pulmonary artery. Okay, so now Hassan was rapidly transferred to the intensive care unit. Okay, he's still unconscious. Swan gans to monitor and urinary catheters are inserted. His father was allowed to come to be at bedside for the first time. So the data obtained on the right atrial pressure, pulmonary capillary wedge pressure, cardiac output, and oxygen contents of the systemic and pulmonary arterial blood were obtained. And this is thanks to the presence of Swan-Ganz catheter. The cardiac pressures were only slightly below normal, but the cardiac output was well below the desired value. The EEG is showing that there is a right bundle branch block, which goes with a shock, and the hemoglobin concentration now is a little bit higher in the range of 11 milligram or 112 gram per liter. So now the fluid is again resumed because we are still managing the shock, although the parameters are a little bit better, but this guy needs more fluids to be better because he's still unconscious. Over the next few hours, the cardiac pressures and the output rose to acceptable levels. Okay. His blood type was type B, Rh negative. However, the hospital is low. The hospital stock so it's a real problem that we are facing right now in every hospital. Don't think that we have everything. Uh, Sorry, I am cut or you're still here?
معاك يا دكتور الله.
Okay. Sorry, I was saying, don't think that every hospitals are having a very good blood bank. Really, we are facing each day a difficult situation of not having enough blood. So I encourage you, if you are healthy and can donate blood, donate because each day the hospital resources become depleted. So we really need blood every day. A lot of patients need blood. So, as you can see in this case, the stock, the reserve for blood is low. So he was giving, luckily for him, they found blood products. So he was giving 2 units of plasma in combination with packed RBCs of group O, Rh negative, which is okay, not the ideal. So in general, we say each patient needs to be given his own type of blood, but in general, O is a universal donor, so we can give to anyone. While all this was ongoing, the hospital tried to contact his relatives. So They are aware of the situation. Emergency surgery was carried out to repair the fractures, tibia and fibula, before he loses more blood and or develop deformities. During the operation, the surgeon encountered a lot of blood from the damaged soft tissue. By this stage, somebody could arrange for Group B blood, and he was given uh, some more units. Altogether, 7 units of blood products were given. Okay, so let's go back. So, as you know, in this case, يعني, it was managed in a good way. But during this period of time, I don't know if it was minutes or hours, he was given a lot of fluids and he was given blood as well. So we need to know about the types of fluids for maintenance and resuscitation. So, of course, first resuscitation and then maintenance. And we need to know what type of blood products we give in this situation. So, in general, IV fluids, and I advise you to read from the book and from the updated books because lots of information now are updated on the types of fluid. So, the types of fluid are in general fall into three types: crystalloids, colloids, and blood products. Blood is considered a fluid. It's not uh, similar to regular fluids, but it's considered a fluid. So you are giving a fluid which is thick and has blood products. So crystalloids. Crystalloids, يعني in general, you can refer to them as salts. So they have electrolytes other small molecules that move freely in the extracellular space. حطوا 10 خطوط على extracellular space. If you give crystalloid and you think it's going to go right away into the intracellular compartment, you might be wrong. So it can go, yes, of course, but it's mainly to replace the extracellular space. Okay, so it increases the extracellular volume, whether it is intravascular or interstitial. It has short half-life. That is why a lot of us prefer it initially because it doesn't stay a lot in the body. Okay, and this crystalloids, it is divided into isotonic, hypotonic, and hypertonic. It is this division is relative to the osmolarity of the plasma. So osmolarity similar to the plasma, so it's isotonic. Hypotonic osmolarity less than the plasma. Remember, we said the plasma. What is the osmolarity of the plasma? If I ask you, the answer is somewhere between 275 to 300 or 290 something milliosmol per kilogram. So if you have a fluid or crystalloid with an osmolarity less than this, example 250 millismol per kilogram, then it is hypotonic. So hypotonic means osmolarity of the fluid less than 250 millismol per kilogram. If you are having an osmolarity more than 375, it is a hypertonic fluid. So when you give the fluids to a patient, you really know you have this data. It is written on the bag that you are giving the patient that the osmolarity is this number. So be aware of that because most of the situation you will give the isotonic, which is normal saline most of the time. But be aware, hospitals are really becoming advanced and you are becoming more and more aware. And believe me, you have more knowledge than me in this. But Most of the time, basic is basic. You give isotonic most of the time. Okay, and these are the examples of the crystalloids. You find it in every hospital. Be aware that you know each hospital and the hospital you are working with, what type of fluid. Okay, so in general, you need to know a few of these or all of them if you can. So crystalloids, they are daily requirements of water and electrolytes. So for example, إذا كان عندكم طفل صغير أو رجال كبير أو حتى أنت you are lacking fluids, you can replace it with crystalloids. يعني تشرب موية. You الموية طبعا ما crystalloid, but يعني in general you know the principle. You give the patient normal saline, you give the patient ringer lactate, you give the patient Hartmann or starch. Sometimes these are crystalloids. Okay, to carry drugs. Okay, so if you have drugs, you can sometimes uh, mix them with crystalloids. Sometimes they have higher glucose, and in patients with low glucose, you prefer crystalloids because they have some sugar. NaHCO3 is very important crystalloid to know it corrects acidosis. Replacement of losses is very important indication as example in this case. So you can give it in resuscitation and maintenance. And these are some examples. Isotonic like ringa lactate, hypertonic like 3% normal saline, hypotonic like 0.45 normal saline. And the isotonic, another example is the 0.9% normal saline, NaCl. Okay, so how, uh, forget about resuscitation now, in maintenance, how to calculate. Remember this rule is very important, especially in the kids. 4-2-1 rule. Okay, 4-1, it means for the first 10 kilograms, you replace it by 4. So, for example, if you have a patient weighing 40 kilograms, then for the first 10, you give 4, so it's 40, plus the next 10, you give 20, so it's 40 plus 20 is 60, and the next 20 you give 1, so you give 20. So in general, for a 40 kilogram you can give 80, which is okay. uh, uh, in adults is a little bit the rule to give 1.5 to 2 mil per kg per hour. So, for example, if you have an adult of 70 kilogram, you can give him around, if you multiply around 2, which is around uh, يعني I mean 140 mil per hour, which is okay, but in general you avoid overload, so you go with 1.5, which is around 100 cc per hour. But this rule is very important. If you go with the 4-2-1 rule, you are safe. The 4-2-1 means the first thing you give 4 ml, the second 10 you give 2 ml, and everything more than 20 kilogram you give 1 ml per kg per hour, and then you add them and calculate. Okay, classification of crystalloids. Crystalloids, as we said, we already talked about it. You know about them a little bit, and learn some examples: isotonic, hypotonic, hypertonic. Another thing, a slide on them. Please be aware of them and read them, as you might have questions in the exams. They are mainly stay in the extravascular space. In the extravascular space, yes. So you give them in the blood, and then they go rapidly to the interstitial space. Okay. What about the hypertonic saline? Hypertonic saline, we like it in neurosurgery because it can reduce edema because it is hypertonic, so it will go to the interstitial space and it will take water from the cells. So it will withdraw water from the cells and the extracellular compartment, so it will specifically for the brain, it will reduce edema, but for the lung, unfortunately, it will cause more pulmonary edema. So you have to have the balance. Okay, what about colloids? Colloids are the second type of fluid. They are different from crystalloids. Colloids, they have large molecules, so they stay inside the vascular space. Okay, so they have long half-life. ما هم زي الكريستالويدز that one they had short half-life. Okay, the increase the intravascular volume and increase the cardiac output, and you have many examples. Mainly, the simple ones are starch, like the penta, heta starches. The albumin is a very important one to know, and it is available. The gel fusin, as in this case, it's made of gelatin, dextrans, and plasma. You can give the plasma of the blood as a colloid. Okay, okay. This is very important to know the comparison. Okay, very important to know the schedule and how you estimate now the resuscitation volume. We already spoke about the maintenance. You remember the 4-2-1 rule. Now the resuscitation volume. The resuscitation volume, whatever lost, simply you need to replace it. So general rule, if you lose blood, replace with blood. If you lose other type of fluid, replace with other type of fluid. A general rule. But this schedule especially in shock, is very important. If you are losing blood, you need to estimate what needs to be given. So, uh, uh, you need to estimate the normal blood volume first. As we said, in male, it is 66, in female, it's 60, okay, the blood volume, and then you estimate how much is lost. For example, if you lost 1 or 4, I mean in the class, and then you calculate the deficit. The deficit is the blood volume times a percentage of what you lost, and then you can replace it with colloid or crystalloids. So if you want to replace it with colloids, you multiply by 1.5. You want to replace it with crystalloids, you multiply by 4. And I think it's reverse. You have to revise it. I think crystalloids you can give a lot, but colloid you can give little. Okay. Blood transfusion, so it's one of the blood products. So you need to know the ABO system, the RH system, typing, screening, cross-matching, the time, and complications. You have many types of blood products. The most important are the packed RBCs, whole blood, fresh frozen plasma, and platelets, and cryoprecipitate, which has some coagulation factors. Okay, so what are the complications of blood transfusion? Be aware of this. Hemolytic reactions are very important, acute versus delayed, non-hemolytic febrile, urticaria, anaphylactic, trally, infections, HIV, etc., massive transfusions as coagulopathy, citrate, toxicity, hypothermia, and acid-base balance. So most important blood products, as I told you, the whole blood, packed RBCs, and The FFBs, platelets, and cryoprecipitate are special products that you need to know about them. They are special giving in special situations like bleeding and hemorrhagic shock. And sometimes they are given if you are lacking particular components of the blood. So fresh frozen plasma, it is should be used in patients with massive bleeding, and you should be giving them early because they are plasma, so they expand the blood volume fast. Okay, so 1-to-1 ratio. So if you are giving fresh frozen plasma and backed RBCs, for example, you give مثلا كيسين دم, كيسين fresh frozen plasma, you give them 1-to-1. Okay, with the force unit of backed RBC. Okay. Platelet transfusion, usually they are indicated if you are having low platelets. For example, if you are having less than 100,000 platelets, they are indicated, and you should maintain a platelet count more than 50,000 platelet per deciliter. So platelets should be given with the sixth and eighth, between sixth and eighth unit of packed RBC. So if you think that, for example، أعطينا أول كيس دم ما نفع، تاني تالت رابع، بعد الرابع أبدأ أفكر بإيش؟ فريش فروزن بلازما. وصلت للسادس، أبدأ أفكر بالبليتلتس because the platelets and fresh frozen plasma will become very essential if you are losing fast the blood. أنت مثلا إذا مثلا عندك أعطيت يونتس والأمور اتحسنت، ممكن قد ما تحتاج تعطي فريش فروزن بلازما ولا بليتلتس. أوكي. What is cryoprecipitate? Cryoprecipitate is very important as fibrinogen. So it is clotting factor that you need to know about. And it should be given if bleeding and حطه تحت خطوط and fibrinogen أقل من 1 gram per liter. Okay. What are the new strategies؟ يعني دحين قلنا في مشاكل كثيرة obtaining البلد. يعني بعض الأحيان ما يكون متوفر، بعض الأحيان يكون في مشاكل، بعض الأحيان يكون there is a problem in the supply. مثلا النوع البلد اللي هو عندنا، مثلا أنت النوع اللي تبغاه O وهو المريض ما عندنا O، ولا النوع اللي تبغاه B ولا زي كده، فهمتوا؟ ف it's very very important to know about this. دحين في techniques autologous transfusion. Autologous transfusion, you take blood that is similar. Blood salvage and reinfusion, you take blood from the patient and you put it again in him. Normovolemic hemodilution in another technique, which is very important, and donor directed transfusion. We bring we bring the blood from specific donor to a specific patient. Okay, so current controversies. So يعني لا تلخبطوا نفسكم كتير. Be stick to the basics. Replace أهم شيء. You evaluate the emergency of the situation, if it's emergency or not, and you replace the fluids as soon as possible. Okay. مثلا كنت لوحدك مع المريض، أهم شيء first your safety, second is the patient safety. سمعنا يعني on the news مسكين المسعف اللي كان بيسعف واحد وهو نفسه خبطته سيارة، الله يرحمه، وتوفى. So be always your safety and then patient safety, but assess patient safety, but assess the situation very fast, and be aware of this. So which fluid, colloids versus crystalloids, endpoints of resuscitation and target hemoglobin. So very, very important so to know about this. Okay, colloid versus colloids for fluid resuscitation critically ill patient. This is a very good review, and you need to know about this. There is no evidence from RCTs that Resuscitation with colloids reduces the risk of death compared to crystalloids in patients with trauma, burns, or following surgery. That's why دحين نحن we prefer always to be safe and give the patient fluids, the safest fluid possible, which is nowadays is the crystalloids, يعني normal saline, ringer lactate, etc. And follow the hospital policy. uh, uh, Endpoint of intravenous fluid resuscitation, you need to know what are the endpoints. Endpoints simply ايش الاوبجكتيفز اللي انتم تبغوها من الريسستيشن. الاوبجكتيف اللي نبغاها من اي ريسستيشن انه المريض يتحسن. فالمريض يتحسن، انا I am following اشياء معينه، اهمها الماب، مين ارتيا بريشر، احتاج يكون اكثر من 65. الأكسجين أحتاج يكون أكثر من 80 preferably أوصله نورمال. اليورين أوتبوت أحتاج يكون 0.5 ml per kg per hour at least. وفي البيدياتريك أحتاج يكون 1، فأحتاج يكون أعلى في البيدياتريك. هيموغلوبين أحتاج يكون هاي more than 9 جرام per deciliter عشان البرفيوجن. اللاكتيت أحتاج يكونوا قليل عشان it's an indices that there is no shock, no acidosis. Okay, and assess the response after fluid challenge. يعني you give the fluid challenge and you assess والله البيشنت improved، البيشنت remain non-improved، أو البيشنت improved and remains improved. So you divide them as responders, partial, non-responder. Non-responder معروفة. Whatever you do, no improvement at all. المشكله في البارشال ريسبوندرز دول. البارشال ريسبوندرز هدول انتوا لازم، يعني مثلا الواحد ما يفرح اذا المريض اتحسن، يعني you give and you assess والله يتحسن وفاضل متحسن. اوكي very very good. So patient improves but shows a gradual deterioration. هدول انتبهوا. Am I doing something wrong? Do I need to give more fluid? Do I need to give more blood? Do I need to give any further policies? Do I need to do more investigation؟ ممكن تحسب انه والله خلاص وقف البليدنج لكنه ينزف في بطنه and you don't know really, so you have to do more investigation and more assessment. So really, really, please, my advice to you, and I know it's a short time, but in fast lecture, but my advice to you, read from big books and read from good articles. And here are some references. The ICU book, particularly, is a very, very good book, and you need to know about it. And lastly, thank you very much. And my email if you have any questions. I think we are done. Do you have any questions? Okay.